So for our standard series in a hip view, we're gonna do an AP pelvis, and then on the affected hip side, we're gonna do a frog leg hip view. That is our standard series. So for an A to P pelvis, we're gonna take a 14x17 film crosswise and put our ID blocker up. The top of your cassette is gonna go 2 inches above the iliac crest. So we palpate 2 inches above. I will line my central ray to that. And now we are at 40 inches image grid, not tabletop, on our column. I will open my collimation to 17 by 14, mark the anatomically correct side. No tube tilt. You have to internally rotate your patient's feet approximately 15 degrees, so have them touch the big toes. Their arms out of the way. Don't breathe, don't move. No filter, no shield. That's A to P pelvis. You can relax. So if I do frog leg view, we're going to use a 10 by 12. Your patient is still supine. The ID blocker goes up. We're going to pretend that it is Dr. Zapay's right hip. That is the affected hip. So for my central ray, it goes at the hip joint. If you want to find a bony landmark, you're going to go 1 inch medial and 3 inches inferior to the ASIS. Can you scoot that way for me? Yes, perfect, thank you. So palpate for the ASIS. It's approximately 3 inches inferior and 1 inch medial. I'm going to line up my cassette. For patient positioning, we're gonna bend the knee and take that foot and put it right against that knee. You're still at 40 inches image grid, no tube tilt. And this one we collimate just under film size. Don't breathe, don't move, no filter, no shield. That's frog leg hip. Always on the affected side.
What if my leg doesn't externally rotate this far?
If you can't externally rotate that far, we would get a foam wedge and put it underneath the knee. I want the pelvis to be flat. So if they can't comfortably externally rotate and they flatten their leg but their pelvis comes up, you compensate by putting the foam underneath that knee so pelvis stays flat. Okay, you can relax, straighten your leg for me again. I'm going to show you the accessory view, the AP spot hip, not part of our standard series. The setup is very, very similar to that of the AP frog leg. The leg position will obviously be different. My cassette is still 10 by 12 lengthwise, ID blocker up, still marking the affected hip. My central ray stays the same, so we're still at the hip joint, 1 inch medial, 3 inches inferior to the ASIS. However, I still need to internally rotate that foot approximately 15 degrees. My collimation would stay the same as the frog leg because I collimated just under film size. Don't breathe, don't move.